Good afternoon, everyone. Thank you for joining us. It is a pleasure to introduce Dr. Alan Ellis, who's going to be talking to us today about LV assessment, and particularly ejection fraction in the critically ill. Alan's a great friend, an old echo fellow here at Nepean Hospital. He works now at Royal North Shore in the eastern suburbs of Sydney. He has his DDU, he's got his American Echo Board exams, applying for the fellowship of the American Society of Echo, which we're hoping will come through soon. And Alan, thank you very much for talking to us today. We really look forward to your talk.
Thanks, Sam. Eastern suburbs of Sydney, east of Penrith, but northern suburbs of Sydney, maybe. Thanks for having me here. I was going to do a talk about one of my pet peeves, really, which is left ventricular ejection fraction, and how we should probably think about using alternatives. I hope these images come out okay on Zoom, because some of the files are quite big, but let me know if you're having any trouble. So left ventricular systolic function is probably one of the most common reasons for doing an echo in ICU. What we really want to know is there abnormal systolic motion? And if there is it a regional phenomenon or is it global? And then at a later stage, we want to know what is the cause of the abnormality. But interestingly, I think it's important to remember that actually you can have normal systolic motion and have a low cardiac output. And I think we see that fairly commonly in ICU, but it's probably under-recognized. That's part of the problem, I guess, with outsourcing much of our sonography, and in that the person who is reporting the echo is relatively alien to the bedside. And is relying on that clinical information to interpret that echo, which is why it's so important that we teach our juniors to put decent information on there, or we encourage us to do bedside assessment in the ICU. So I'm going to talk about sort of 4 or 5 various scenarios. I'm very aware that my former teacher, Sam, is in this meeting. So if there's anything incorrect or not quite right for DDU purposes, then I would encourage him just to flag it up.
I won't interrupt. I'm sure it's going to be perfect. You talk beautifully.
So when is left ventricular ejection fraction not always normal, and when is it not a reassuring thing to see? So I'm not going to talk too much on low afterload and preload, because that comes with ICU, and we see that pretty commonly. And the other ones I'm going to focus on more is a little bit about the less common times we might see a normal left ventricular ejection fraction reported, but the patient might be in cardiogenic shock. And I'll go in a bit more into detail about that. So I thought I'd start off by asking, and I know we've got maybe 4 people online, asking what is a normal left ventricular ejection fraction? And this is where I was going to have a poll, but maybe if anyone wants to just spout out a number, assuming a male, for example, what would a normal ejection fraction be?
So normal ejection fraction would be more than 53% for a male patient. And it's usually a range rather than an absolute number. So it's about 50 to 55%. And this reflective of the global systolic function rather than any regional wall motion abnormalities.
True, yeah. Any other takers on ejection fraction? It's a pretty simple question, but you'd be surprised how many people don't know what normal is. I know that everyone in this group will know, but okay, well, we'll move on then.
Alan, would it be important to say, do you remember when you say normal and had some saying about the range, so it'd be like 53 to 70 or something?
Okay.
So
if you've got a echo report back from the echo lab, what number would you be comfortable is normal? What is reported as a normal range?
yeah, I'd say 53 to 70.
Any others changes on that? Well, I guess the answer is it depends. And this is shamelessly stolen from Twitter, but I think it's a good illustration about how, depending on where you are in the world, they have different ideas of what the normal ejection fraction is. And small changes around normal 50 to 55 range is not a big deal. But other places, they categorize them differently. And for our purposes, we often use the ASE guidelines as being mild, moderate, and severe. But interesting, if you look at the British guidelines, they say that anyone with an ejection fraction less than 35% is severe. because they say, well, if you've got less than 35%, that's when the real evidence comes in that treatment makes a difference. Whereas you can see various other associations have slightly different ranges, and no one really can agree. And even the British version has this sort of, borderline low normal, which I hate the term low normal. It's either low or it's normal. But they've got this range in there. So in a nutshell, in Australia, or certainly in the labs that I've been involved in our hospital, we use ASC guidelines, which is 52 and above for a man and 54 and above for a woman, right? But thereabouts is pretty okay. And the ASC give you an upper range, or the others kind of don't. And this is sort of the document that sort of describes a lot of those normal ranges, and we don't need to go into that because that's obviously available online. So we're going to go through a little bit about measurement of ejection fraction. This will come as no surprise to anyone, but the left ventricular ejection fraction is the stroke volume divided by the left ventricular end diastolic volume. There are other equations like left ventricular volume, stroke volume equals left ventricular end diastolic volume times ejection fraction, those sorts of things, but same sort of thing. And normal, if you think about it, your normal stroke volume is about 70 mils, and your normal left ventricular end diastolic volume is about 120 mils. We'll remember that from our anesthetic from ICU primaries, roughly about 58%. Let's just have a look at this image. So this is an image, or sort of a loop done at one of our study days on one of our trainees, and it kind of nicely illustrates part of the problems with assessment of ejection fraction. Does anyone have a guess of what the EF there is? I mean, it would be good for a poll to see how much it might vary. But this is a standard parasternal long axis view. Anyone want to hazard a guess? But is it normal or abnormal, do you think?
Well, I'm getting a very low frame rate here, but it doesn't look normal. Yeah,
so sorry it's not coming out very well, but this is part of the problem in ICU. We've only got Spark machines here, so this is it's not just an equipment thing, but it is also a patient thing. So we've got a perfectly healthy trainee having an echo, and one of the trainees who we're doing the study day with said that doesn't look normal. It freaks the person out who's having the echo, but this person is perfectly normal. So it's difficult because you can see that even with in the right hands, there is the problem with equipment, and you can sometimes not see the endocardial border particularly well. But this chap was perfectly well, and he was very fit. He had a normal ejection fraction when you looked at the other views. But it just illustrates even standard views on normal people, you can have suboptimal images, and makes the interpretation of ejection fraction quite challenging in some cases, even under the optimal conditions. Okay. So how do we go about it? And it largely depends on where you work and your practice. The vast majority of echo labs will probably, the bulk of their work will be subjective assessment in an experienced hands. But there are others out there that sort of allow you to use mathematical models to determine what the ejection fraction would be. We'll go into a little bit of that a bit later, but also just don't forget that there are also non-echo ways of working out ejection fraction. We're probably all familiar with ventriculogram, but we're also going to see more commonly used things like cardiac MRI reporting ejection fractions. I think you're going to get a cardiac MRI soon at the P90 exam, but just probably not so much in the ICU population, but you might see it on some reports. So to illustrate that point, when I was writing this talk, this patient came down from the Central Coast, and in the morning they'd had an echo where this echo was reported as an EF of 45%, and they were coming down from the coast to have their leads extracted, I think it was. Anyone agree with that assessment of 45%?
I think that's very generous.
Any takers saying that? Would you say it was mildly impaired? No, I think
well, again, from the frame rate that's coming through, but in taken in totality, the size, the mitral valves, the right heart, this is severely impaired on just a qualitative view of these loops, I would say. it does not look like 45%, no.
Yeah, and so I think it just illustrates part of the problem with subjective assessment, because the same patient had an echo in the morning up the coast and it was reported as 45%. And then this echo that was done here, same day, no change in management or condition, was reported as 25%. So a big difference in ejection fraction, which is why I always say to our trainees that even if, if it doesn't fit right, don't trust the echo report necessarily, have a look at the pictures, okay? And just make your own assessment sometimes. It's important to remember that even in experienced hands, if you're having a bad day, or you're going through hundreds of loops, as you might be if you're reporting all day, you might not have an accurate EF report. And so that patient went to theatre and I think was going to have their wires removed or something like that, and that was just a toe image. And it looked a lot more stark on that toe image, but I just thought this is a good image because it illustrates another phenomenon that you might see when patients have abnormal, or could argue it's a normal variant of systolic motion. And I don't know if that's coming out very well on Zoom, but anyone see what's going on with the intraceptal wall?
Well, it looks dysynchronous. I mean, you don't have any ECG gating, so it's hard for me to tell what's going on, but it looks like the intraventricular septum is dysynchronous with what you'd expect. But whether that's pacing, if this patient has a pacemaker lead in, it might be pacing related. But yeah, I mean, is that what we're talking about?
Yeah, I think it looks nail on the head. So sometimes this is reported in echoes and things as a dysynchrony, but this is just someone who's paced, and I think that wall motion would be normal for this patient, if that makes sense. Anyone disagree or agree? All right. So I won't touch too much on that, but I think, I don't know, you might know more about this than I, Sam, but I don't think there's been any significant large study to compare subjective assessment with measured ejection fraction and validated subjective assessment.
There are in the cardiology literature, not in the critical care. There's I don't know about the size. I mean, hundreds of patients, and they've had a look at different groups of people, from med students to people who have just been trained in it to experts, and they've done the same thing as strain analysis and stuff. And it's not surprisingly shows that if you're just learning, the range of different things is huge. As you get more and more expert, those ranges come closer together. So if you're an expert in echo, the people agree in a narrower state, and they compare that to MRI, and it's okay, is the bottom line.
And so I'll talk a little bit about some of the methods of assessing, I guess, ejection fraction. This isn't really ejection fraction, it's fractional shortening, which is again another measure of systolic function. It's not the same as ejection fraction, but it's just based on geometry, a bit like you described there, where you look at two segments and you measure the contractile performance, then you measure the end systolic diameter and the end diastolic diameter, and give it those numbers. The normal range is 27 to 45%. In some places will report that, and others will use the same sort of numbers but punch them into some form of equation, which basically assumes this shape, I can't remember what it's called, but this cylindrical cone-like shape of the left ventricle, which we all know is not true, but it assumes that and gives you an estimated volume based on those measured parameters. Tycult is another one which actually gets reported quite often in our units, which really only looks at two segments, but it's basically looking at that fractional shortening and punching those numbers into an equation. And you can do it in M mode, or you can do it on 2D, but it just works out an ejection fraction. But it can be woefully inaccurate if you, for example, have hyperdynamic basal segments that are very knackered apical segments, and you might see that with something like a Takasubos. So again, you have to have a bit of caution with how you interpret these numbers, and if they get reported, it's worthwhile just looking at the images yourself, I think. Here's another mechanism, which is just the areal length method, where you use clinimetry to measure the area, the mid, and then you measure the length of the apex, and then again that just assumes the sort of bullet shape and gives you an estimated end systolic and end diastolic volume. But the one that we probably come across most often these days is Simpson's method, and that's probably not too bad. And it's pretty reliable when you've got good images. Part of the problem though is this same patient that we did earlier. Yes, I've got my focus point and not in the ideal spot, but you can see there that particularly with not too uncommon with the two-chamber view, you get dropout of the anterior wall, and similarly with the four-chamber view, you get dropout of the anterolateral wall as well. So it makes even in good conditions in a young fit patient, you can sometimes get suboptimal images, and you can't really do a formal Simpsons biplane. The Simpsons is basically where you measure the endostic volume and systolic volume, or area, I should say, in two planes. And again, it's a bit of a fudge factor, but it's called the method of discs, whereby you work out these disc volumes, you add them all together, and then that's how you work out your endostic volume and systolic volume, and therefore your ejection fraction. But the problem with ejection fraction is it doesn't necessarily always tell you about systolic performance. And the one thing that those of you who've worked in echo labs is that you can often get patients who walk into the clinic perfectly fine, and they're not breathless, they've got no symptoms, and they walk in and you do an echo, and you look at their echo images, and you look at the patient and think, how are you alive? Because their ventricle is terrible. And you look at it and think, well, these people have clearly had it for a long time. And that's one of the challenges when you do echocardiography and you get images like this, you need to know, well, is this new or old? Certainly, if you've got someone walking in with this sort of image, it's probably old. So never forget, obviously, to put it into clinical context. But anyone has sort of discuss sort of the upper left image about what they think the systolic performance is like? No takers?
I'll have a go. It looks bloody awful. Yeah, absolutely severe systolic dysfunction. I want to know what your poker face was like. If this was an outpatient, do you sometimes find it difficult to not sort of have that look of horror on your face as you do that first view? You've got to try and keep a straight face. It's hard sometimes.
You never quite know what to do with them, whether to send them into ED or to send them home.
Yeah.
But invariably, someone who comes in with these pictures, and we see them quite often because they come back every year for echoes. They have this sort of horror of an echo. But that said, if you look at some of the pictures, it's thin-walled, the left ventricle is dilated. You can tell it's dilated because you can see the measurements on the left-hand side, the upper left image. If you look at the aortic valve, for example, that's vigorously opening. And although you could say that, the only real wall that's twitching is the infralateral wall, there's obviously flow there. And you could argue that with the aortic valve opening well, you could say, well, this probably is an okay stroke volume going through there. I very much doubt it's normal. But these patients often have low stroke volumes. You can see this chap's got a heart rate in the 120s, and he's compensating to some respect. And so you could argue that systolic performance might be okay. So it's important to interpret these in the clinical context. Anyone else have any comment there?
Yeah, Alan, I think it's just these nicely emphasize how, ejection fraction, or however we talk about it, myocardial performance is reflectant not only on contractility, but also really influenced by loading conditions. And it'd be interesting to see how much, for example, how much mitral regurg is going on here. I suspect there's a reasonable amount. Yeah. And how if, the afterload changes or preload changes, how the overall myocardial performance or cardiac output will change as well. And I was just going to point out about the heart rate. I suspect that, there's going to be a high left ventricular end diastolic volume, and that's probably the thing that's saving the patient in terms of being able to use some of that for a reasonable stroke volume, but being able to mount the tachycardia is probably the thing that's allowing him to hang on for a cardiac output perspective.
I agree completely, and there's some clues in that image, isn't there? That left ventricle is dilated. You can see that the in the four-chamber view that there's this just looks loaded and pressure loaded, and the left intraatrial septum probably from some decent MRI is bowing over to the right. You can get the impression that heart is a loaded left ventricle.
And Alan, as well, the small area of the lung that you can see down on the parasternal lung axis is actually showing a lot of B lines.
Yes, I think you're talking about the bottom right image, or
no, on the top right. On
top right from the pericardium.
Yeah, exactly. Yeah, so just below that, you can start seeing some B lines across the lung here.
Yeah.
And even on this one, on the short axis.
Would you get picked up on that in the exam, Sam? Can you call them B lines if they're arising from the pericardium?
Yeah, I think it's a good question. I think it's a nice pickup, and just an important point I guess I learned from that is looking at the whole echo image, make sure you're not missing things behind. I think you can see that there are B lines, maybe it's more on the parasternal long axis view almost, where you're going to have that there, those lines at the back. I think you should say there's a suggestion of it, and you'd be wanting to have a look at the rest of the lung image, but I think it's a really nice pickup. He's clearly got signs of raised left atrial pressure with a big left atrium, intraatrial septum pushed over, bad systolic function by definition. There's got to be some bad diastolic dysfunction in there. MR, because you don't have the mitral valve coaptation, looks like it's poor. So I think it's a nice idea to suggest this guy might have some interstitial fluid involved.
So while I'm talking about chronic versus acute, there are other clues that suggest that it might be a chronic phenomenon. Does anyone want to comment on this echo? Anything that suggests it might be a chronic phenomenon? I hope it's coming out all right. Might be better in the next image.
So my myocardium is very thin and it's akinetic. The apex is dilated. So that's all features of chronicity.
Is the increased echogenicity as well?
Well, I think there's a reason why they've increased the gain. Does anyone want to guess why? Well, if you look on the left-hand side, there's probably some sessile thrombus there within the apex, and they've deliberately increased the gain looking for it. And is that coming out all right?
They could deliberately move the focus as well, but yes, I see what you say.
Yeah. So I mean, things like if you see a bit of thrombus, or for example, an aneurysm, it's more likely to be chronic, isn't it, than an acute thing. But it can also be that even in an acute setting, they can be hard to pick up these sort of subtle regional wall motion changes, or these systolic changes, I should say. In this view, overall, if you eyeballed that, you'd probably say that was normal systolic function. But this is where you need to be a bit careful, and I think experienced eyes. Does anyone notice anything about perhaps the image on the left? Whether or not there's a regional or global problem?
Basal infraseptum is hypokinetic.
Yeah, I think so. And I think you're right. I think although the whole ventricle looks like it's moving, not everywhere is thickening. And if you look at the interseptal wall, and to some extent a little bit of the inferior wall as well, but I think it's mostly interseptal, it's not thickening around about here. Can you see my arrow? No, maybe not. And the rest of it's functioning fine. So you just need to bear in mind that regional changes can be quite subtle, which is why I always tell our trainees in ICU, you shouldn't be commenting on regional wall motion abnormalities. And that's why, because you pick up your coronary regional ischemia using your echo. So trying to address what the cause is, if there's a regional wall motion abnormality, and I guess that goes back to basics, and it's history exam, your ECG, and if you can convince a cardiologist, angiography. Other things that can help to determine the etiology. I'm not going to spend too much time on this, but if you work in somewhere like Nepean and you've got someone who can't go for an angiography, you can always do diffusion imaging. And I won't spend too much time on this because it's obviously something that I don't think you'll get asked about in your exam, and I don't think not everyone will be familiar with it. This essentially it's this thing called perfluorocarbon, which is very small bubbles that are very echogenic, that allows you to assess perfusion, because these are so small they pass through the coronary circulation, and you end up with something like this, whereby you inject the diffuser, you reduce the mechanical index so that you don't destroy the bubbles on your ultrasound probe, and you're looking to see point at which the myocardium, the speckles start to show, the bubbles start to show. And what you need to do is compare a region of what you think is a normal regional wall motion versus the sort of area in question, and then you use computer software really just to assess it. And I think this is probably a patient I looked after in the PIN a while ago who was quite sick, and we weren't sure if the changes we were seeing were due to takotsubo versus some ischemia. We kind of thought it was a takotsubo, and we did the diffusion imaging, and we put two regions of interest on the myocardium. So you can see a yellow circle and a green circle there, and you can see what you're looking for is this acoustic signal that the bubbles are arising, and then you give a high intensity ultrasound to destroy the bubbles, which is this big jump on the graph, and then you look to see whether or not the return of the bubbles happens at the same time on that on the bottom bit there, where you see the green and the yellow following each other, and then they were kind of similar, so it shows that they've probably got reasonably preserved perfusion. I won't spend any more time on that. Was there anything you wanted to say there, Sam? I'm sure you won't get that in DDU exam.
Absolutely, it won't be in the exam, but I think that's very nicely described, absolutely, suggesting that you've got normal blood flow. As long as we just know it's not perfect, it's very research-based, it's challenging imaging, no way is suggesting that this should take place of angiography or anything else. It's just another tool in the arsenal, I guess.
And then obviously you can use the same contrast to look for clots as well. And if you've got crappy images, you can also use that contrast to help you with working out your ejection fraction.
I recognise that scan.
I do. It's more common in the US, I think, because they've got more money to spend and they use it a lot more commonly, I think, the contrast. But we certainly don't see it very often here at North Shore. So I'll get into the crux of our talk today, which is when is ejection fraction not always normal? And I'm not going to spend too much time on afterload and preload, except give you maybe an example. So these are all patients that I've looked after in the last, say, year. A 50-year-old admitted with neutropenic sepsis, actually got intubated for pulmonary hemorrhage, and then developed shock. Came down to the ICU, and then the first echo on the left there, they're the hemodynamic numbers there. Sort of looks like it's reassuring, right? Any comments on the left one? Looks pretty hyperdynamic, you think? No one talking, all right. And then obviously, they're in the ICU. When they came down, they're, having lines put in, their mean arterial pressures, terrible. And then you start them on some noradrenaline. This person was particularly sick, and they're feeling pretty cold and shut down the modules, and you're wanting to make sure really that you're not missing anything. So you repeat the echo maybe 4 or 5 hours later, and on the right is what you see. Then on want to comment about what they think systolic performance is. It's not a great parasternal long axis. Because you've got the inferior pap muscle there showing up. You don't really want that in your view. But there's something else on that parasternal long, which they'd expect you to pick up on if you're in the DDU exam. Anyone want to comment?
Alan, the first thing, is this patient in PA arrest or asystole or electromechanical, because it's flatline ECG down?
Oh yeah, don't worry about that. That's just me being naughty and not plugging in my
Yep.
ECG.
Okay. Second thing, that there is a possibility of spontaneous echo contrast in the left atrium, and the mitral valve is not opening as the previous one just 4 hours earlier.
Are you looking at the right image?
I'm looking at the left now, at the right image. Yep.
Yeah, I think that's probably artifact there, if I'm honest. I don't think that's spontaneous echo contrast. There's something, what do you think? I don't know if you can see my arrow, but what do you think about this bit here behind the pericardium? If you look at the history.
It looks like consolidated lung underlying here as well.
Yeah, so they'd expect you to pick that up in the exam. You know, you've got a history of pulmonary hemorrhage, and this patient was ventilated, quite difficult to ventilate. But you can see that once you've modified the hemodynamic parameters with vasopressors, the left ventricle looks a lot less hyperdynamic, at least I think so. And obviously it's a crappy image because they're now ventilated and it's quite hard to get windows, which is always the case, but that's the nature of critical care echocardiography, isn't it? So I'm not going to spend any more time on that. I'm going to talk a little bit about valvular regurgitation. Okay, so we're all familiar with this equation. We've talked about it up till now. It's important to remember that if you've got a severe or even moderate valvular regurgitation during systole, in health, most of your blood flow goes out through your left ventricular tract, up through your valve, and to your body. But in severe regurgitant disease, you can end up with some of that stroke volume going back into the left atrium, following the path of least resistance. And if you remember your ASC guidelines, your severe mitral regurgitation is a regurgitant volume of more than 60 mils or regurgitation fraction more than 50%. Obviously, you're going to integrate all your findings to determine whether or not you've got severe MR. But if you take this as an example, what you've actually got is you've got a left ventricular ejection fraction is a composite of both your stroke volume and your regurgitation volume, which makes your left ventricle look hyperdynamic. I'm going to talk a little bit about that. So this is actually a patient who, as always, comes in the middle of the night. It was this echo, it's a really good echo done by one of our ICU trainees, and he sort of flagged it up in the, on the phone. Do you mind looking at this echo image? It's just not right. They come in with pulmonedema. They're on CPAP. They're on some NORAD, and the X-ray looks terrible. Does anyone want to comment on that echo loop? I hope it comes out well. It probably isn't because it's a Spark, crappy resolution, and we're on Zoom. But it's got a clear pathology there, so I'm hoping one of you can pick it up.
You hear that, Alan? We had a call here for maybe there's something wrong with the mitral valve leaf and an ruptured cord or something.
Yeah, I think you can see there, I don't know, I describe it as a very wibbly bit hanging off the end of the anterior mitral valve, and I hope it's coming out, but a very restricted posterior leaflet. Yeah. And so the trainee put on some color. What do we think about this color box? Obviously, I'm not sure if you can see the color scale on that image. Yes, you can. Do you want to comment about what they think the severity of the MR is there and why?
We'd like to pick on Emma for this one. Emma's our current echo fellow. I do want to do this.
I might be a bit kinder and just show you the next one because we've trained our trainees very well. And so, oh, no. There you go. Is that coming out right? There you go. So we've increased the color box. What do you think, Emma?
Oh, I can't, hang on a sec. Oh, there we go.
So I'm being a bit jumpy.
So even based on the acute, I mean the 2D image, I'd be concerned that this is going to end up being severe MR just based on the 2D alone. And then with the color box wasn't, sorry, I can't, none of them are playing for me now, Alan.
Oh, sorry. Let's go back to that one. I can't get that one on loop. There you go. But there's a few clues onto there that tells you why. You obviously hit the nail on the head. It's severe. But why
yes.
Is it severe? You talk about the 2D, I agree. There's definitely a coaptation defect, and there's a bit of ruptured cordy, the wind. Anything on that image that makes you think this is severe, even in that small box?
With that small box, well, there's flow convergence, and we have a PISA, and it's looking like it's going to be an eccentric MR, so an anteriorly directed mitral regurgitant jet. Obviously the color box size itself and the position is not optimized, but the scale looks reasonable to be able to make that assessment.
Yeah. I agree completely.
Yeah.
I think there's a flow convergence there, isn't there? And although if you're doing a true PISA, you need to modify your color scale slightly, but I think based on what the 2D shows, that flow convergent and that eccentric jet, I'd be pretty happy that was severe. And certainly looking at that.
Which way is it going?
Sorry?
Which way was it going? Just Emma, you said you, which way do you think the regurg jet's going? You said anteriorly or posteriorly?
I think she meant.
What have you gone? I think you said it was anteriorly directed. And I think probably it's going posteriorly directed, because if you have a flail, it flips down, and so it goes in the opposite direction. So it was the anterior mitral valve leaflet that's
posteriorly directed. Posteriorly directed on that.
Yeah, no.
And we could drop the color scale down to 40 as a cheats method, and then if the Pisa radius was more than 1, that might be suggestive of.
Yeah, and I do that all the time. I find that I think I was taught that tip by Louise, and it's a good one. And no one ever really uses Pisa that much, and I certainly don't. But I always remember a length more than a centimeter is usually indicative of severe MR. And certainly, when you've already picked up as well that it's an eccentric jet, if you want to make any comments about that type of jet and the problems with estimating MR with that type of jet, do you know what the problem might be?
Well, sorry, it is posteriorly directed. The difficulty with eccentric jets in estimating with just using color, and I guess more quantitative things like Pisa, are that like in terms of angle correction, is difficult because of the shape of the shell. It's not truly hemispheric, so that can alter the accuracy of measurements. Just by the nature of them, eccentric jets are more difficult to assess severity on because of the inertia that you get from the wall hugging phenomenon with the Coanda effect. And so often the velocity, therefore, that we're seeing, with the color can be, you can underestimate the severity with eccentricity.
And I agree. I think that's the magic word, isn't it? That Coanda effect, which makes it difficult sometimes to interpret the severity. All right, so this is just the same patient, and you can see it's always a bit more obvious on toe. You've got a very clear coaptation defect there on the left-hand image, and a very nice both flow convergence and an eccentric jet that goes right up to. Does anyone know what that pointy bit's called? I'm sure you all do. And what's above that? Let's go back to anatomy.
It would be the Coumadin ridge.
Yeah, and what vein is that?
The left upper, that would be, I think.
Nice, yeah, great. And so if you've got, if you get, what do you find the left upper?
I think it's called the ridge of Morgani, isn't it, Alan?
Huh?
Isn't it the ridge of Morgani? Is that right? No.
I thought it was the Coumadin ridge.
No, it's the Coumadin ridge, the ridge of Morgani. I think I've been teaching that for about 3 years, and then someone told me that it's actually it's found in the sphincter of the anus, the ridge of Morgani. So I always laugh. I was saying it the other week. So it's Coumadin ridge. Much as I hate to label it up. No, you're totally right. It's me. I was teaching it wrong for about 3 years. It just makes me laugh every time.
I need to Google the other one now. All right, or maybe not. All right, so yeah, left upper. What would you find in left upper pulmonary vein if you've had this phenomenon? Do you think anyone else? Maybe someone else? It's a very common DDE question with severe regurgitant lesions. You're going to see flow reversal. Yeah. All right, I might move on. And this is just out of interest. This is the same patient having a toe. What else can we see on this image? Just as an incidental OMA, really.
Bicuspid valve, is it? Or am I just seeing it wrong?
Yeah, no, I agree. It's bicuspid valve. Any other clues as to why it might be severe MR in that image?
The intraatrial septum is bulging.
Yeah.
Right across.
Did everyone see that? I don't know if my arrow is coming up, but you've got a bulging intraatrial septum there. It probably shows it's got a nice intact septum, despite the bicuspid valve. Everyone happy with that? So this patient went on and had a MVR, AVR. And what do you think? This is them coming back after theatre. What do you think about systolic function now? Same heart, that there were different loading conditions and no regurgitant volumes. Ignore the pericardial effusion. But does anyone get that there's obviously been a significant change in, because the systolic and contractile function of the heart probably hasn't greatly changed, even though they've been on cardiopulmonary bypass probably for a decent period of time. They'll almost invariably come back on a inotrope like milrinone. But you can see that there's a dramatic difference in systolic performance in that same patient because they've had the valves changed. Everyone happy?
Yeah.
Everyone's very quiet. This is a different patient. So this is a patient that actually, weirdly, and I think you've seen this a couple of times, people who are surprisingly well despite the pathology found. So this is a bit more obvious, this one, but does anyone want to comment on what the pathology is with the mitral valve in this one? Samar, Lewis, Young?
There's a vegetation, mobile mass over the anterior mitral valve leaflet tip. This a long axis view on mid-esophageal, transesophageal scan, and it's definitely affecting the mobility and coaptation of the mitral valve, so leading to, again, I would get larger color box, but again, this more likely representing a severe mitral valve regurgitation. I can't see the color scape.
What do you think the actual pathology is? What's the cause?
Infective endocarditis. So there's a big vegetation over the anterior mitral valve leaflet tip.
Yeah, that's possible. Sorry, I should give you a bit more clinical history, but this is the chap who had an inferior STEMI a couple of days ago.
Yeah.
He's popped his pap muscle.
A pap muscle, yeah.
Yeah, so this is pap muscle rupture with, I go a bit further than saying severe MR, I'd say torrential. And what you'd see with torrential MR is, what would you see on a Doppler of the regurgitant jet? Do you know?
So it would be hollow systolic, it would be, hollow diastolic, and it would be the depth of the, the gain over the color flow, over the continuous wave Doppler would be quite dense.
Yes, it'll be dense, but anyone want to jump in? What's the classic?
Is there a cutoff sign?
It would be a triangular cutoff sign, like the V.
So that's the pathonomic feature of a torrential lesion, is you get this triangular rapid equalization of pressures between the chambers in a very dense jet. Everyone happy with that? And this guy's got a completely knackered mitral valve. And this is, I got asked this in my DDU exam, but you need to know a little bit about your pap muscle anatomy and hazard a guess if you've got an inferior STEMI where you might end up rupturing your pap muscle. Yeah?
Yeah, can I jump in there, Alan? Just from the echo side of things. So, Alan, you obviously had this in your exam, I remember, and this is a really common exam kind of question or sort of ethos behind it in terms of showing someone a transesophageal echo. You're expected to know your anatomy. You're expected to be able to identify the valve leaflet. Absolutely, if you can get the scallop, that is preferred. It's not always a absolute pass or fail, but you've got to get the leaflet, you've got to get the walls in a transesophageal echo image. And also, I think the important thing that we examiners are looking for is the idea of clinical context. You know, I'm not just asking you to report the echo, I'm giving you the stem, or you're given the stem for a very important reason, because it's about and integrating the echo findings into the scenario. So if you're seeing this, and like Alan has told you, you know, this guy's come in short of breath and he's on some inotropic therapy or something and intubated, you know, saying to the words, don't let the examiner have to force it out of you. And this is a medical emergency. We need to get cardiothoracics to have a look at this to fix the valve. This is not going to fix itself. You know, give that clinical tie it up in a nice bow at the end of it.
And similarly, if when you go and do your exams, you can figure out that that's the anterior leaflet, and if you've got an inferior STEMI, what the likely chunk of the pap muscle that's been pulled off is. I mean, that always looks nice, I think. I got it in my exam, and I have to say I probably fudged my way through that a little bit. And then obviously this is after having the valve fixed. And what do you make of the systolic performance then? So this guy came in looking quite well. He goes and has his surgery, and he has his valve replaced, as Sam described, and he comes back and he looks shocking. He's terrible. And you almost wonder, why did you send him for surgery? because he was fine beforehand, but obviously they couldn't leave that. And what do you make of the systolic performance now? Same patient, about 5 hours later. Severely impaired?
Yeah, severely impaired, looks pretty parlous. Yeah, severely impaired systolic function.
I think that guy, I think all I did was crank up the mirror in them, but he was all right. Sorry, I'm a bit running out of time, running over time, Sam, but I'll keep on going. So next case, which is probably what you'll almost certainly get asked about at some point in your DV exam, is the phenomenon of dynamic obstruction. And often with this, you'll see someone have a hypodynamic ventricle, and usually in the context of some low afterload, or occasionally in someone who's got pre-existing HOCM. And it's always a good one for exams. Does anyone want to comment on that echo image there? What the cause might be? 82-year-old, uroseptic, rising pressure requirements.
Well, I mean, he's got a very, sorry, no, you go.
Lewis? Anyone? Okay.
Yeah, sorry, it's Jamal here. I mean, he's got a very prominent intraventricular septum, which is very concerning. I mean, it looks like a number of centimeters. There's no color on it, but the 2D morphology would suggest that he's got some SAM there. And I mean, keeping in mind, I mean, he's got rising pressure requirement. That would be a thought. But yeah, it looks like he's got systolic anterior motion of the anterior leaflet of the mitral valve, aggravated by that intraventricular septum, and I'd want to confirm this with kind of his hemodynamics and his color flow Doppler to see what his MR looked like and what direction it was traveling in.
Yeah, so yeah, I agree. It's SAM. SAM is one of these things that I think is grossly overdiagnosed, but also underdiagnosed, if that makes sense. And when you've got it, it's you feel great about finding it, but it is a challenging thing to fix sometimes. And you should always think, if you haven't got any associated MR with it, then you kind of have to question the diagnosis. And that's kind of what you're looking for. Was it Jamal?
Yeah.
Yeah.
Can I make one real quick comment just for those if they're starting out? Sometimes I think I found it difficult to see the systolic anterior motion for a while, and one of the tips and tricks that was explained to me is don't look at the anterior mitral valve, you look in the middle of the ventricle, and you use almost your peripheral vision to pick up when the systolic motion is. You know, I sometimes find it's hard when you're tachycardic to pick up when systole and when's diastole. And so if you're looking in the middle of the valve, looking at the middle of the ventricle, you can see the walls come together very clearly, and that's when you see that anterior motion of the anterior mitral valve leaflet being pulled into the LVOT. So you look in the middle of the left ventricle, as you see the walls coming together, that is systole, and you should not have that anterior mitral valve leaflet being pulled into the LVOT. Yeah,
I agree, Sam. I think it is hard when you've got rapidly moving things. And I think my big tip for this is M-mode. And it's one of the few occasions that you might actually find M-mode pretty useful. And the reason for that is because it's got a very high temporal resolution, and that when you are looking at rapidly moving structures like the mitral valve, you really want the best resolution you possibly get. And you can look in a couple of views. This one's the short axis view with the M-mode cursor across the mitral valve, and this is where the ECG is your friend. And you look for systole and look to see where the mitral valve leaflet tip is. You really do need Doppler to assess the severity of the obstruction and address the gradient. But M-mode can be really helpful just to see where, if you're looking in systole, which is the beginning of the QRS to the end of T-wave, the mitral valve should be closed. But if you've got that leaflet open and hitting the left ventricular outflow tract wall, that's not right. So you really need to think about SAM at that point. And this is in the short axis view, but this is a bit more of an obvious case in the long axis view. There's no ECG on this, which is, again, that's my fault. This is one I've dragged from the internet, but that's where ECG, I think, and M-mode could actually help pick it up. And then you have to go on and try and assess the severity, where Doppler comes in. And you're usually looking at very high gradients, so you need to be using continuous Doppler, right?
They love this in the ASE exams. Anyone sitting in the American Echo Board exams, they love M-mode, and it's the classic picture.
In fact, the only time I'll ever use M-mode, if I'm honest, because M mode is, I don't know, it's just one of those things that's a bit.
And what about
I
perhaps-
love it in the exams, but I have to say it is useful for SAM, and it's really quite satisfying to demonstrate, even to a cardiac surgeon, in simple terms, that SAM is going on when they just don't believe it. Do you know what I mean? To spell it out, because it's quite good to look at. But it can be tricky, and this is another example of where you really need to slow things down and use your ECG. And this is one that Stephen Huang gave me a while back ago, and it's. Anyone want to hazard a guess what the pathology is here? Anne-Marie, you're in the back there, very quiet.
Amyloid?
Yeah, could be. I think that,
Right.
is there anything on that 2D image you think that suggests that there might be some obstruction going on?
Well, the thick septum, it's very thick.
Yeah. What do you, if I was to say, look at the aortic valve, what's it doing that it doesn't normally do? Do you think the right coronary cusp looks like, if you remember, look back at when you have a M mode and someone's got a severe aortic regurgitation and they have that sort of oscillation movement of the mitral valve lead. I think you see a little bit of that with the aortic valve, because you've got a high flow jet going through it.
Yeah.
And you've got some sort of oscillation of that right coronary cusp. Does anyone see it? It's probably hard on Zoom.
It's hard on Zoom, I think.
Yeah, just to illustrate the 2D image of obstruction.
Nice.
And this, I think, is one of your papers, Dan. No, it's Michelle Snyder.
I know Michelle Snyder was one of my favourite papers. So I think it's fantastic and just clearly identifies utility of echo in the critically ill. It's a beautiful paper.
And I'll come and I'll talk more about that. But I think we often underestimate how many patients have intraventricular obstruction, and that's classic because we think of the ventricle contracting from the apex up towards the base, but we know that in an empty heart, the mid and the base might be more hyperdynamic than the apex, and you might get obstruction either mid cavity or from the papillary muscles, or even the for example, if someone's got a sigmoid septum, and you can have that intraventricular obstruction, and it's not always due to sound. Okay, and this is an example. This is handed over to me on a Friday afternoon. A bit of a hospital past, but the patient, he's 23 milligrams, max 60. His index is terrible. She 2 or 3 days down the line post cardiac surgery, cold, clammy. Although the lactate wasn't that impressive, she had sort of mottled knees, and that sort of 2D image is the best I could get on the transthoracic. And although the 2D is not particularly helpful, does anyone want to comment on that? Is it coming out all right?
Good kissing ventricle sign.
Yeah. So it made me think, or maybe there's a bit of mid-cavity obstruction going on, and this is where Doppler is your friend. Anyone want to comment on these Doppler traces? Trace? Obviously, I'm looking at the mitral inflow at that point, and then I see on the mitral inflow, there's this thing, this aliasing phenomenon coming from above.
Yeah, well, as you say, you're using pulse wave, so you've got range sensitivity, but you may not be catching the highest velocity, and you're only picking where you think the obstruction may be, and you're obviously limiting yourself in terms of gradients you can see. But that's at that point that's quite high, and whether or not you have like a classic kind of scabbard shape, obstruction that you could kind of reinforce with continuous wave, but that immediately already does look concerning.
Yeah, so you touched on there, but what do we call this profile when you see it? I guess it's got a classic obstruction, has a classical profile that you see with Doppler trace, and although the pulse wave won't be able to tell you the necessary peak velocity or the peak gradient, you can see from the shape of the trace that there's likely to be some obstruction going on. Everyone with me on that one?
Yeah, so the dagger shape or the saber tooth.
Dagger shape. Okay. Yeah, so that's what I saw, and then there's a bit more there, sort of mid cavity, and yes, it's pulse wave, but it sort of has that dagger shape. Yeah, because you need to go hunting for it, even though the gradient might not be measurable. You need to know where along your cursor the actual obstruction is occurring. Yeah. And this is not the same patient, but that's a very sort of textbook dagger shape, but obviously a lower velocity, low gradient. Okay, and that's a continuous measurement, and you can see that the velocities can get pretty high. All right. The treatment there is just filling, not very exciting, but we should have a couple of bottles of albumin or something. I don't know if you want me to keep going, Sam, but this just to touch briefly on 2 occasions when you might
sort of running out of time, Alan, a little bit. We're up to the hour mark.
That's all right. Do you want to do that another time then?
You
probably time
for a few questions. It'd be nice to hear if anyone wants to ask you anything. Are you happy to talk about pericardial constriction a bit later, Alan? Is that okay?
Yeah.
Thanks.
Yeah.
Alan, that was a brilliant talk covering so many things in there. It's absolutely fantastic. Maybe just ask if there are any questions for Alan.
Alan, I just had a question about the last one with the, you know, when you're suspecting dynamic LVO, but the gradients that we think of in HOCM are like over 3.5 and then I guess over 5 meters per second. Even if if you had someone with a terrible LV, right, and you put that through and you get that sort of dagger shaped profile and you're suspecting it, even if the gradients weren't high, that would still be classed as a sort of dynamic LVO, would it? What kind of gradients in meters per second do we still use that 3.5, 5 sort of range, or can it be lower than that?
When we're talking gradients, we're talking pressure changes, aren't we? So if I'm not sure what the range would be in a dynamic process, but certainly when you've got HOCM and you're trying to elicit a gradient that's measurable, you'll take the peak velocity and measure the peak gradient. And if it's more than 30,
being 50, more than 30 and 50, is it? So more than 30.
More than 30 is significant, but more than 50 is severe. And I think that's certainly what I recall. But in dynamic processes and not in the context of HOCM, you can generate much higher gradients. And we saw an example there of someone who had a gradient, I should say a peak velocity, which translates to a gradient of 4 or 5 meters per second, which places a significant stress on myocardial work. And in the critical care sphere, you can't leave people working at that degree of obstruction because they'll infarct. Does that make sense?
Yeah. Thank you.
Can I add something just in? I think it's important to differentiate between interventricular obstruction versus LVOT obstruction, because any gradient that you're seeing in interventricular obstruction is suggesting some form of kissing ventricle sign happening, which is associated with hypovolemia. And that's the finding that Michel Slama and his group found on that multi-center study that was done in 2015 in patients with septic shock. And that was associated with worse outcomes, like a doubling in the outcome, and that was a sign of hypovolemia. So that's a little different from what you're going to find in the LVOT obstruction. So I think any kind of dagger-shaped trace that you're seeing on continuous wave Doppler down through the LV, when a patient has this hyperdynamic LV function, that is associated with hypovolemia, and that is significant.
Thanks, Sam. Thanks, Alan. Yeah.
Were there any other questions for Alan? If I might just ask one, Alan, can you just summarize again? So if you're seeing a patient who is on catecholamines with an ejection fraction of 60% that you think is normal, you're suggesting therefore that we don't just immediately jump and say, oh, this is normal systolic function. You're trying to put it into clinical context.
Yeah,
so
I think that's part of the problem when we ask for echoes from outside providers. You've got someone who, you shouldn't be treating the echo, you should be treating the patient. So if you put your hands on their knees and they're cold, they're in cardiac shock. The fact that you get a report saying that LVAF is 60% or they're hypodynamic should ring alarm bells that there's something else going on. And there's another process that means either they've got a low cardiac output state despite normal systolic motion, which could be everything like I discussed, from low afterload, reduced preload, an obstructive phenomenon, some pericardial constriction, a restrictive pathology, pericardial tamponade, these sorts of things. And I think you often hear people talking about this lingua franca of what normal LVO function is, and it provides sometimes a false reassurance that just because the LVEF is normal doesn't mean their cardiac performance is normal. And I think you shouldn't detract away from your gut feelings and intensitous. Press the flesh, look at the bigger picture. If their lactate's 12, and they're cold, they're shut down. The fact that they have a hyperdynamic LV means there's something else going on.
Very nice. Alan, thank you so much for your time. I really appreciate your talk. I hope we can try and bring you back to maybe finish off about the constrictive pericarditis and things like that. And we just, really look forward to hearing you talk more. Thank you very, very much indeed.
All right, thanks.
If you learned something, hit like and subscribe to our channel for more videos uploaded weekly.
For bite-sized versions, follow us on Twitter @EchoNepean and check out the tutorials.
Or head over to our websites for the latest hands-on courses. Links in the channel banner.
And thanks for watching.